Hello, my name is Brelynn Burzynski, and I am a DNP FNP student at Maryville University. Today, I'm presenting my DNP project titled Improving Nursing Adherence to the Leaf Patient Monitoring System, Enhancing Repositioning Practices through Audits to Prevent Hospital-Acquired Pressure Injuries. Committee members for this quality improvement project include Dr. Maria Snell, the DNP chair member, Dr. Doug Bartelt, second reader in Nursing 707 faculty, and Dr. Josephine Areola, community member and house supervisor at the practice site in which this project took place. At the project site of this quality improvement project, repositioning practices were poor, with 44.3% turning compliance, resulting in increased relative incidence of hospital-acquired pressure injuries, or HAPIs. The LEAF patient monitoring system was implemented by leadership as an attempt to reduce HAPIs at the organization. The LEAF monitor is a wearable adhesive device that attaches to a patient's chest, detects their position, and then notifies nursing staff when the next repositioning is due, which is every 2 hours. An economic evaluation demonstrated that the LEAF patient monitoring system reduced HAPIs by 70% with an estimated cost savings of $6,621 per patient. Yet, the technology was underutilized at the project site, as eligible patients for a LEAF monitor were not having one placed by nursing staff, thus inhibiting the cost effectiveness of the intervention. Nurses were responsible for identifying patients who were candidates and placing the LEAF monitor. However, this required nursing knowledge of the LEAF inclusion and exclusion criteria, which was cited as a barrier to the technology's usage at the project site when conducting the needs assessment. Therefore, this quality improvement project aimed to identify and implement an evidence-based intervention that improved nurses' compliance with the LEAF patient monitoring system. The review of literature aimed to answer the following question: what are strategies to improve nursing adherence with the healthcare technology system, specifically the LEAF patient monitoring system, in order to decrease the risk of HAPIs? 3 themes emerged from the 11 peer-reviewed primary research articles: education, routine feedback, and value perception. These themes serve as influencing factors to the successful implementation of a practice change and/or healthcare technology system. First, the lack of proper education, training, and preparation for a clinical practice change, i.e. the adoption of a healthcare technology system, is consistently cited to be a barrier to successful implementation. Not only is initial education and preparation important, but ongoing educational opportunities also support compliance with a practice change in healthcare technology. Therefore, continued education and training must be a priority to increase nurses' confidence in the technology's use. After adequate education and preparation for a practice change, there must be an intervention to sustain the change. To do so, the literature revealed the second theme: routine feedback. Leadership must provide routine feedback and monitoring to ensure nursing compliance with the practice change. Routine feedback in the form of audits is identified as the most successful intervention to sustain change in compliance with a practice change. The third influencing factor of the successful implementation of a practice change is nursing perception of the value of the change. Nurses want to know that the change is valid and will not be a waste of their time and efforts. The LEAF patient monitoring system communicates with the charting software and provides automated repositioning documentation for nurses, thus reducing the amount of time nurses spend charting. This finding may promote value perception among nurses at the practice site towards the LEAF patient monitoring system, as it allows nurses to spend more time in their shift engaging in direct patient care and less time documenting. The theoretical framework that aligns closely with this DNP project is the technology acceptance model, a behavioral model developed by Fred Davis in 1989 that predicts one's overall attitude or acceptance in using a new technology system. The technology acceptance model has been applied to technology implementation in many different industries. The model identifies two cognitive factors that influence one's attitude and actual use of technology. One being the perceived ease of use, and two being the user's perceived usefulness of the technology. To first address the ease of use of the Leaf patient monitoring system, the audits utilized as the intervention in this project were designed as a user-friendly flowchart that also served as an educational tool. The flowchart served as a visual guide that helped nurses to decipher if a patient was a candidate for a Leaf monitor. A mere list of the inclusion and exclusion criteria may seem daunting to nurses and make learning the criteria more difficult, thus cultivating a perception that the technology is not very easy to use. To address users' perceived usefulness of the technology, in the pre-implementation phase of this project, nurses were given background information that a particular benefit of using the technology is decreased charting burden, given that the technology automatically documents patient positioning in the electronic health record for the nurse. The final desired outcome of this project was improved use of the healthcare technology system, the Leaf patient monitoring system, which is why the technology acceptance model was the most applicable theoretical model. A quantitative exploratory pre- and post-intervention design was used for this quality improvement project to measure change in nursing compliance after the implementation of weekly audits using two data points: the total number of Leaf candidates and the number of Leaf candidates with a sensor actually in place. The setting of this project was on an inpatient medical, surgical, and transitional care unit at a critical access hospital in the Midwest region of the United States. The medical, surgical, transitional care unit cares for approximately 1,000 patients per year, with length of stay averaging 1 to 2 weeks. The evidence-based intervention utilized in this project was weekly audits provided to staff nurses to serve as a form of routine feedback and continuing education on the Leaf patient monitoring system. Audits were handed out to staff nurses on both day and night shift every Sunday for a total of 8 weeks. The audit tool was developed by the researcher and utilized as an intervention consisted of the Leaf inclusion and exclusion criteria in a flowchart format. A flowchart format was used as it provided a decision-making framework for complex processes and required minimal time to complete as to not create a time burden for staff nurses, which also could have decreased nursing participation in this project. The data collection instrument used to retrieve the total number of Leaf candidates on the unit consisted of a report that was generated by the electronic medical record. The report used nursing documentation in the EMR to comprise a list of patients that were candidates for a Leaf monitor and required the every 2-hour repositioning based on the Leaf's inclusion criteria. The total number of candidates with a Leaf monitor physically in place was obtained by viewing the central monitor located at the nurse's station, which displays the room numbers of patients with an active sensor. These two data points were then inputted into an Excel spreadsheet daily during 4 weeks of pre-intervention and post-intervention data collection. Using these two data points to generate a proportion representing nursing compliance before and after the intervention phase helped to answer the question of inquiry regarding whether audits improved nursing adherence to the Leaf patient monitoring system. The participants of this project were patients admitted to the inpatient unit where the project occurred who were Leaf candidates based on the inclusion and exclusion criteria. The inclusion criteria for a participant to be a candidate for Leaf monitor included the following. The patient was over the age of 18. The patient is admitted to the medical, surgical, transitional care unit. The patient has a current pressure injury, a Braden score less than or equal to 18, and the patient has an incontinence episode charted at any point during admission. Factors that exclude a participant from needing a leaf monitor are the following. The patient is admitted as observational status with an anticipated hospital stay of less than 24 hours, or the patient has one or more of contraindications to a leaf monitor, including an adhesive allergy, being too wiggly or anxious, a medical device in place that would interfere with the placement of a monitor, or being pregnant. Here is the audit tool that was utilized as the intervention in this project. The presence of a current pressure injury automatically indicates a leaf sensor unless there is also a contraindication to a leaf sensor. If the patient does not have a current pressure injury, then they do not automatically require a leaf sensor unless the patient's last charted Brelynn score is less than or equal to 18, and the patient has had an incontinence episode charted at any point during admission. If those true criteria are met, then a leaf sensor is required, unless, again, the patient has a contraindication to a sensor. You can see how moving through this flowchart format is quicker and a little easier to understand versus looking at a mere list of the inclusion and exclusion criteria that was on the previous slide here. You can just kind of see the difference. An upper tail z-test for the difference of two proportions was used to determine if there was a statistically significant difference in nursing compliance, i.e. the proportion of leaf candidates with a sensor in place, before and after the implementation of weekly audits. Analyzing pre-implementation data and post-implementation data allowed myself as the researcher to determine if the intervention impacted the state of the practice problem and to gain some insight into its sustainability. The results of the data analysis revealed that the proportion of leaf candidates with a sensor in place post-intervention was statistically significantly higher than the proportion of candidates with a sensor in place pre-intervention. The results of this project demonstrated an improvement in nursing compliance following the implementation of the intervention. During the 4-week pre-intervention data collection period, 33 patients at increased risk for pressure injuries were placed on a leaf sensor, while 100 patients were not, resulting in a compliance rate of 24.8%. Following the implementation of weekly audits, data collected over a 4-week period of post-intervention data collection showed that 199 at-risk patients were appropriately placed on a leaf sensor, while only 27 patients were not, resulting in a compliance rate of 88%. This represents an increase of over 60 percentage points in compliance, indicating a strong positive impact of the intervention. These findings support the effectiveness of routine audits as a strategy to drive rapid practice change. The magnitude of improvement observed over a relatively short time frame highlights the potential for the scalability and application of this intervention to other units or clinical settings. Despite the results, there were some limitations identified that may have impacted these results. First, the length and time between the needs assessment and the implementation of the project was nearly 1 year in length. This caused new, more pertinent needs to be identified by nursing leadership. However, the project was too far along to change completely. The fruition of more pertinent needs caused nursing leadership support in the project to fade as time went on, which may have swayed nursing attitudes towards the desired change. Additionally, during the post-intervention data collection period, the organization announced that the leaf patient monitoring system would be retired during the following month. This came as quite a surprise to the researcher and the nursing leadership team. The project finished in its entirety. However, this announcement may have swayed nursing compliance with the technology, given that it would no longer be in use in the near future. The results of this project demonstrated statistical and clinical significance and highlight the impact that routine audits have on nursing compliance with a practice change, and specifically the leave patient monitoring system. The role of audits as both a feedback mechanism and a form of continuing education are believed to contribute to the intervention's success. Rather than serving solely as a monitoring tool, audits provided ongoing opportunities for staff to reflect on their practice and reinforce the correct use of the technology. This learning approach helped to bridge knowledge gaps and supported the technology's use in a clinically relevant way. Furthermore, the use of a non-punitive educational framework appeared to play a key role in staff engagement. By removing the fear of punishment and instead emphasizing support and learning, staff were more receptive to feedback and more willing to adapt their practices, as evidenced by the improved compliance rates with the technology. This approach contributed to a noticeable cultural shift as well, particularly in staff usage of the leave patient monitoring system and how repositioning practices were viewed and carried out within the unit. These findings are consistent with existing evidence that supports audit strategies as effective methods for sustaining practice change. Overall, this project reinforces the idea that successful implementation is not just about introducing new processes or technology, but also about fostering an environment of continuing learning and support and accountability. This project's implications for nursing practice are multifaceted. First, implementing routine audits offers a practical and low-cost approach to improving compliance with healthcare technology. These audits help ensure that best practices are consistently followed without placing a significant financial burden on the organization. Second, providing educational, non-punitive feedback in the form of audits encourages positive staff engagement, fosters trust, and supports a culture of continuous improvement rather than fear of punishment. Additionally, improved compliance with healthcare technology directly enhances patient safety and overall quality of care, which remains a central priority in nursing practice. Greater utilization of existing technology also increases organizational cost effectiveness by maximizing resources that are already in place. Finally, these strategies support nurse satisfaction and may even help reduce burnout, particularly when changes are implemented and reinforced in a supportive and structured manner. Overall, these implications highlight the importance of combining accountability with support via audits to drive sustainable improvements in nursing practice. In conclusion, the use of routine audits was effective in increasing nursing compliance with the leave patient monitoring system. This approach not only reinforced best practices, but also supported ongoing learning and engagement among nursing staff. The project also suggests that supportive implementation strategies, such as non-punitive and educational feedback, can positively influence nurse satisfaction and may even help reduce burnout, particularly when staff feel empowered rather than evaluated. Overall, these findings emphasize that sustainable practice change is best achieved through a combination of accountability, education, and a supportive organizational culture. Looking back, one area of improvement would be incorporating additional stakeholder input to further strengthen the sustainability and long-term outcomes of this project. Moving forward, I plan to continue advocating for the use of audits in the form of continuing education as a standard approach to practice improvement. There is also an opportunity to expand this work by scaling the intervention across additional units and exploring its impact on broader patient care outcomes. On a personal level, completing the DNP program has significantly improved my growth as a nurse leader. This experience has strengthened my ability to translate evidence into practice, evaluate outcomes, and lead meaningful change within complex healthcare systems. I've also gained a deeper appreciation for the importance of collaboration, adaptability, and data driven decision making. Ultimately, this journey has prepared me to serve as a change agent in nursing practice with a continued commitment to improving patient care outcomes, supporting staff, and advancing quality and safety in healthcare wherever my career will take me. Here is a list of my references, and thank you so much for watching.